Hi, everybody. Okay, we are going to talk today about clinical language and using strengths based language in our documentation. I know I've given everybody lots of suggestions and things to think about in regards to your um, session notes and all of the other assignments. Um, but I thought it might be helpful for us to have just kind of like an overarching little presentation on it. I'm going to include in this, I'll make sure you all have the slides also, but I'm going to include in this just some suggestions of specific language, specific phrases, um, other things to kind of think about as you start really developing your clinical writing skills. Um, and I'm also going to cover just some other important considerations in regards to our clinical language and clinical writing. Okay. So why does this matter? Why does language matter? So our documentation is not just for us, right? Our documentation is for the families, it's for the clients, it's for the future clinicians that might be working with this individual, it's for the entire treatment team. And language really reflects how we view our clients, right? It communicates what our values are, it communicates assumptions. Um, and because of that, it can either really reinforce harmful narratives like deficit based thinking, ableist thinking, pathologizing our clients, or it can really reflect and recognize their autonomy, their dignity, their capacity for growth. Okay. So something that I would love to just kind of plant, a seed that I would love to plant, is if you think about your clinical writing and you think about if this note was written about me or my loved one and I read this, would I feel respected? Would I feel seen? Would I feel like the struggles that I have are not being minimized or um, exaggerated, or assumptions are being made about me as a person and what I'm experiencing? Or rather, would I read this and feel like the person who has written this note about me is in my corner, is working to see me, is working to find ways to communicate, is is supporting is supporting me in my journey, right? So deficit based language really centers what our clients are lacking, right? So I'm going to throw a lot of examples at you in this presentation, but I think it can be really helpful to hear sort of the alternatives to some of this writing, so that you can really start to synthesize this kind of language. Okay, so here's a deficit-based language example. The student is nonverbal and low functioning. They do not initiate communication and require maximum prompting to participate. Okay. A strength-based alternative for that could be the student communicates. How are they? What are they doing? Right? This is what I'm always saying to you in your feedback. Not what they're not doing, what are they doing? The student communicates using a variety of modalities versus they do not initiate communication. The student does. Everyone is communicating something somehow, right? The student communicates using a variety of modalities, including gestures, facial expressions, and AAC. They engage most fully during familiar routines and benefit from co-regulation. So within that, I'm reading as a clinician who maybe doesn't know this client, Okay, so, if this is an autistic kiddo that we're working with, they need routines, which might mean, if you were focusing on a deficit based way of presenting this, um, you might have written something around like, tantrums or meltdowns, right? Um, but we're going to focus on the strengths based language. They engage most fully when familiar routines during familiar routines and benefit from co-regulation. With consistent partnership and sensory access, the student shows curiosity, humor, and connection. That is such an affirming, lovely way to express that, right? Um, so thinking about our writing used to empower and not diminish our clients. So deficit-based language can really reduce a person's humanity to their challenges, and we don't want to do that as therapists. And I really do think that the way that we write reflects how we think, and vice versa. If we really try to channel this strength-based thinking in our writing, it can also influence really how we do feel about our clients, right? Client was resistant and did not follow directions, versus client expressed a need for autonomy and explored alternate ways of engaging. It's so different, right? So we're highlighting abilities, resources, and progress rather than limitations, okay? And and challenges can be framed as areas of support, not defining features of the individual, right? So always focusing on what the client can do in our writing. What can they do? What are they interested in? What are they drawn to? Not what they're not doing, what we're not seeing, what they're failing to do. Okay. So we're going to talk a little bit more to, I think in here somewhere, maybe I didn't put a specific bullet about it, but just neuroaffirming language. A lot of us are working with neurodivergent folks, and neuroaffirming language avoids implying that someone needs to be fixed or normalized. So we're accepting and validating neurodivergent ways of communicating, regulating, and experiencing the world, okay? And avoiding that being pathologized, that being a negative behavior, and recognizing that these things that we see are functional, they're adaptive, they are part of their experience. Okay. Okay. Oh, one more point. I have some notes here. You guys know I get a little long-winded, but if our documentation focuses on deficit-based language, it contradicts our therapeutic goals, right? We're self-determination and empowerment. If we are using affirming and strengths-based language in our notes, that models client-centered values for the whole interdisciplinary team. And sometimes that is really needed. Okay. All right, next slide here. Okay, so just some things, and you guys can go back and reference this. I'm not going to spend a ton of time going over all of these specific examples, but some general tips. And we went into depth with these things in therapeutic processes, but it's always just good to have a refresher. We're using objective and descriptive language. We're saying what happened, not what we assume happened. And so here's an example. The client turned away and covered their ears. That's what happened. Versus our assumption, client was non-compliant. Do we know that they were being non-compliant? Like, what was happening in their internal experience? So we're making that assumption that they were choosing not to comply, right? That's our assumption. Client turned away and covered their ears. That's what happened. Center the client's agency. So using verbs that reflect autonomy, they initiated, chose, requested, preferred, or demonstrated preference for. Focusing on functional communication and participation without judgment from us. So here's another example. Client took space under the table and hummed rhythmically to self-regulate, versus client had a tantrum and refused to participate. Do you see how different that feels? Client showed preference for drumming versus client was non-compliant and refused to engage in singing, right? So these are just like small changes in the way that we write, but can really change the way that others are perceiving of the client, or like the information that they're gathering about the client, and also reflects our our picture of them, right? Our values, our empathy. This picture here is not relevant, sorry. It's just a template. Okay, so here's just some more examples. I figured you guys can always just benefit from having like kind of a word bank. So replacing passive or deficit based phrasing. So we don't use nonverbal. Non-speaking is the language that is preferred now. Doesn't initiate. Benefits from co-regulation. Low functioning. We don't use functioning labels anymore. That's another important thing to say. So we don't say low functioning autism. We don't say profound disability. Okay. So we're going to use phrases like high support needs, or you can use the phrasing that's now with autism, the levels, right? And so you can read up on the levels of autism: level 1 autism, level 2 autism, level 3 autism. Requires support in areas of X, demonstrate strengths in areas of X. Uncooperative, communicated preferences to not engage. Tantrum, dysregulation, right? These are just important things to consider. So then here's a list of observation and evidence-based phrases and some more client-centered phrasing. And you can read these examples. Always the as evidenced by is a great phrase. Demonstrated by, these are great phrases to incorporate. Okay. Some more language suggestions. Using transition and progression of the session language. So one of the things that I've kind of noticed with some folks' clinical writing as you are developing this is sort of repetitive sentence structure. Client did this, client did this, client did this, client did this. So think about how you're kind of structuring your overall note, and think about using these transition progression phrases over the course of the session. Compared to previous sessions, client continues to benefit from, is building tolerance for, right? These kinds of phrases can really help with the tone and with the pacing and overall feel of your clinical writing. Okay. Then here are just some helpful verbs: objective, descriptive clinical writing. You guys can look through this. These are some different domains or categories rather that that you might be writing about. Okay. All right. Okay. Respecting identity. This is something that is also really, really important for us to think about in our clinical writing. So a lot of folks have learned person first language, and there is a huge shift away from that and using identity first language. Of course, we are always going to honor the individual's preference. But a lot of folks in the autistic community are now preferring autistic versus person with autism. So in general, I think defaulting to the identity first language, even if you don't know that individual's preference, is more neuroaffirming and aligned with what the disability community is currently advocating for. And we are always wanting to listen to the communities that we are working with, right? It is not our place to say, no, I'm not going to use that language because XYZ, right? So we are going to use autistic versus person with autism, child with autism, um, in general, identity first language, okay? Of course, if there's a person who prefers to be referred to as a person with autism, then that's their choice, right? But again, defaulting to what the communities that we are working with are advocating for and prefer, okay? Um, I think the reason behind this is that a lot of autistic folks are saying this is not just something that I have, it is part of who I am, right? So it using that identity first language is really uh, validating that, okay? Avoiding euphemisms like differently abled, okay? Like they can be really dismissive of the person's lived experience. That differently abled does not include all of the like real life challenges and hard things that disabled people have to experience. So don't be afraid of using terms like disabled. Okay. Pronouns. I feel like everyone at this point hopefully is understanding of being respectful of somebody's pronouns. We always need to use pronouns correctly, consistently. If someone has not disclosed their pronouns to you, use neutral language. And this is another thing that's really, really important, and especially something to think about in our current climate. Do not out a client in your notes. So if you are working with a trans person, a gender expansive person who uses one name or pronoun with you in sessions because they feel safe in sessions with you, but they have not shared that with their family or with their school, documenting that could put them at risk. So you just need to always ask these questions to yourself before putting it in writing, okay? And preferred pronouns are just pronouns. Like my pronouns are she, her. Those aren't my preferred pronouns. Those are just my pronouns, right? So preferred, don't use the word preferred. They're just pronouns, right? Okay. Respecting racial and cultural identity too. It's important to not make assumptions about somebody's race, ethnicity, or cultural background based on their appearance or surname. And also think about like, is this therapeutically relevant for me to mention? Um, I think these things are really important to recognize, and I think they're things that happen um, often. Okay, I identify as a mixed race Filipino American woman, right? And if I was reading something that referred to me, and I have seen this on like medical charts referring to me as white, and I take offense to that. That is not my identity. That's not my lived experience, and that's not how how I identify. So making assumptions about somebody's race or background based on the way that they look, or saying, "Oh, well, she's not um, Asian enough," right? Those kinds of things. Like it doesn't really matter. That's not my lived experience, right? I'll just use myself as an example. Um, so the language should reflect who the client says that they are, not who we assume they are or what we assume their experience is. And again, think about, is it relevant? Is the racial identity of your client relevant to note? Not always. Sometimes it's going to be. Sometimes it's not going to be, right? And think about that too, just like in day-to-day life. Capitalize identities, capitalize Black, capitalize Latinx, Indigenous. Um, these are just important things to think about in terms of our our documentation as well. Okay. Okay, and then this again. So instead of preferred pronouns, just use pronouns. Ethnic or minority music, be specific. Don't generalize, right? Don't make assumptions. Transgendered is not a word that we use. It is an adjective, not a verb. Transgender. or trans, normal or typical. Instead of that, use common, neurotypical if that's relevant. And again, write with safety in mind. Ask yourself, if a parent or administrator reads this note, could it potentially put my client at risk? And that goes for clients who have undocumented statuses. If they share information in a session with you about that, that should not be documented. Migration history, family status. Asked, am I protecting this client's safety, identity, and autonomy in what I choose to write down? Okay. Is it relevant? You don't need to tell the entire story in a note, just the relevant ones and with care. So these are just things that are really important to think about, like the legal implications of our documentation, okay? The safety implications of our documentation. Okay, clinical writing tips. I kind of covered this already, but varying our sentence structure. So instead of the client entered the room, the client sat down, the client began to drum, the client smiled, right? All of that. So it's so choppy. It doesn't like the overarching, the overall feel of that is very disconnected, right? Upon entering the room, the client sat near the instruments and reached for the drum. They began playing a steady rhythm and smiled when the therapist joined in. Start some sentences with time markers, use action-based transitions. So these are just some things to think about. Okay, so our clinical tone is clear, respectful, professional, not robotic. Don't use casual or vague language. The client was super into the music and did a great job. No. The client demonstrated strong engagement during the drumming activity, maintaining a steady rhythm and imitating several musical exchanges with the therapist. Okay. These are just some, and you know, this is not like a one size fits all, right? Like everything is going to be, there's, I might have given you feedback on something in the past that you're like, oh, well, that contradicts what she's saying here. Everything is going to be also context based, right? So here's some phrases to think about. Casual phrase: liked it, showed preference for, did really well, demonstrated increasing independence, seemed happy, appeared joyful as evidenced by smiling and vocalizing. Okay, so I'm just throwing a bunch of things out here at you. These are all just kind of food for thought, things for you to consider. In your writing as you are going about doing clinical documentation, as you're going about writing assessments and treatment plans, and really honing in on the way that that you're documenting. Okay, so in conclusion, words matter. They really do, right? You're helping someone shape you're helping shape how someone is being seen by the treatment team. And I really do think that I've been a part of so many different treatment teams over the course of my career. And I really do feel like music therapy can shift the way that other folks who maybe are coming from a really I don't know, behavioral background, of very maybe burned out, maybe they're really um, just not thinking about their clients from an empathetic lens. I really do think that music therapy and music therapists can shift that in the humanizing way that we approach the work, because music is so humanizing, right? So every time we are documenting, we are advocating for our clients. And language is powerful. It can reflect our belief in a client's humanity and their potential and their agency. So by using a strengths-based, neuroaffirming language, we are being ethical, we're being client-centered, and it's not it's not just happening in the session, it's happening in our documentation as well. Okay. So yeah, that's my little documentation spiel for today. Let me know if you have any thoughts, questions. We can talk about this more in group supervision. You can shoot me an email. And I will talk to you guys soon. Hope you're doing well.